All right, so chest tubes. We talked a little bit about this when we talked about all the pleural effusion problems that patients can have, fluid, air, all that kind of stuff accumulating around the lungs. But now we're going to really talk about these devices, how they work and what we're looking for. So what is a chest tube? This is the chest tube drainage collection device. This one is a wet suction. I can tell because chamber A is full of water, not air. So that's how I know this one's a wet suction. We talked about needle decompression. That's the one we do way up high. That one is for our tension pneumothorax, to relieve that pressure so we can do that life-saving intervention for patients with tracheal deviation. For chest tubes, like a long-term insertion, where patients are going to have this thing for a few days, we're really going to be going in on the lateral side of the chest, the fourth-ish kind of intercostal area, depends where the level of their effusion, how much fluid they have in their lung. But the surgeon is going to put all this in, and we are responsible for maintaining this part of the device, which is going to collect all the drainage in that pleural space. Key thing, it's a gravity drain, so it always needs to be below the level of the patient. So we use these to treat spontaneous traumatic pneumothoraxes, hemothoraxes, empyemas. We use these post-operatively to help re-expand lungs and remove excess kind of fluids associated with surgeries that involve the lungs. So after partial, total lobectomies, they'll come out with chest tubes. And it's to re-establish negative pleural pressure. That's inspiration, right? Where we're creating negative pressure in the thorax so inspiration can happen. Expiratory positive pressure is when, that contraction of the chest pushes air out. Gravity we talked about, suctioning we've talked about. Kind of here's where the things go. A lot of this part's kind of review from our pleural effusion stuff. But it goes between the lung bag and the lung in the pleural space where that fluid can accumulate abnormally. Allows the lung to re-expand fully because we don't have any fluid volume that's causing kind of restriction of how well or effective the lung can expand. Types of drainage systems that we use, water seal is the most important part of all of them. The water seal is the part that actually closes off our patient from just having an open tube sticking out of their lungs. So they can ventilate appropriately, not just move muscles. When patients don't have an appropriate water seal, they can develop a tension pneumo or a sucking chest wound, which is that one that causes tracheal deviation, which is like super bad. Patients should not have that. The dry suction and wet suction has to do with the different types of devices and how they're built in order to manage the suctioning part of the drain that we can apply to a patient to help kind of take an active role in removing some of that fluid accumulation from the pleural space. Here's the devices. So same things exist in both of them. The big differences are around the suctioning components. So the suctioning here is in chamber A, which on our wet suction is this big tall chamber here, which is going to be full of water, and the water level will vary depending on the level of suctioning applied to our patient. -10, 15, 20. So that's our suctioning level, is -10, -15, or -20. When we've got our dry suctioning, we just dial this little guy right here to -10, 20, or 30. So same level of suctioning. We can do a little more suctioning on our dry suction devices, but the way we do it's totally different. Instead of filling with water, we just turn the dial. Okay? The collection chamber is the part with all the numbers. It's exactly the same on both devices. The key thing there is we just need to make sure we're marking how much drainage we get out of these things every shift. So we're doing very strict I's and O's on how much fluid collection is happening in these devices, regardless of the type of device. And then our water seal chamber is the most important chamber. It's the one that allows negative pressure in the thorax so that patients can inhale normally. and don't have a compromised respiratory system. And it's exactly the same in both devices. So it's chamber C, and we should not see any bubbling in that chamber. If we see bubbling in that chamber, that means there's an air leak, which is bad. Attached to chamber C is chamber B, which is our tidal volume, or titling. So there's a little ball in here that as the patient breathes, as they breathe in, the ball goes up. As they breathe out, it goes down. And that's normal. That should be going on every time a patient breathes. So we talked about the reasons. Just a quick review. So a pneumothorax, pneumo meaning air in the pleural space. Hemothorax is blood in the pleural space. And an empyema is pus in the pleural space, all of which we got to get out of there because all of these are causing incomplete expansion of the lung, meaning incomplete gas exchange is happening for these patients. So for our chest tube inspection, the way that I always do this is I start at the patient and then work my way to the drain. Okay? So first thing we want to do is inspect the dressing, meaning the insertion site of the patient. So we want to take a look at that. And then we also want to check the device. Make sure that there is water in the water-sealed chamber and that there's gentle bubbling in the suction container if it's a wet suction device. If it's a dry suction device, we want to make sure that the bellows right here is expanded, meaning that suctioning has been applied. It's that little accordion, looks like a little dog toy that kind of pops out once suctioning is applied to that patient. Then we want to palpate the patient around the dressing site. We're palpating the skin around where the tube goes in, looking for subcutaneous emphysema. It's going to feel like crepitus, kind of like that grinding or crunchy feeling that patients can have in their joints, but obviously there's no joint there. There's just air trapped in the skin around that insertion site. It might feel like if you have sand in your fingers and you kind of rub it around, that kind of feeling. It's not normal skin. If you feel anything weird around that area, that could be subcutaneous emphysema, meaning there's an air leak and some of the air or fluid is leaking into their subcutaneous tissue, not into the drain, which is bad. If this happens, we want to call the surgeon or the physician and report that finding right away. Not up to us to decide what to do about that. Definitely up to us to identify that finding and report it. Then we want to auscultate. So we're going to listen with the bell of our stethoscope, so the kind of bigger, deep sound part, right around that insertion site. What we're listening for is any leaking air around the insertion site. Then we're also going to listen to the lungs and make sure that the patient is having crackles. Right? So crackles are that sound of re-expansion of the lungs. If we start to hear crackles, what do we do with our patient after that? IS, right? Because we want to increase ventilation, make sure those alveoli stay open so that gas exchange can happen. So we always listen to lung sounds and listen bilaterally because patients will be different left to right lung because of that abnormal fluid accumulation. So, if the chest tube becomes disconnected from the patient, step 1, take a deep breath, freak out a little on the inside. Step 2, time to spring into action. So if the chest tube, meaning the part sticking out of the patient, becomes disconnected from the collection device, from the actual drain, we need to take the chest tube and stick it in sterile water. Meaning whatever part is dangling out of the patient, just take a sterile water cup and put it in there. It can be sterile saline, sterile water. The key thing here is sterile, because we need to create that water seal so they can ventilate appropriately. After we've created a water seal, then we assess our patient. Listen to their lungs, have them speak. They should be able to ventilate appropriately. They should not have any signs and symptoms of respiratory distress. No look of panic feeling, normal respiratory rate, normal oxygenation, that kind of stuff. Once we know our patient is okay, then we're going to get a new chest tube drain, so the actual drainage thing from central supply, like they'll have to bring it up. So we may have to be hanging with this patient for a little while, and we're going to hook it up. Once we've made our patient safe, then we're going to notify the physician of what happened, what we did, and what our physical exam is. If your patient is in respiratory distress at any point along this kind of procedure or this kind of chain of events, call the physician immediately and report that and tell them what you're doing about it. They may want something else done, but probably this is exactly the procedure they want to have happen as quickly as humanly possible. So keep marching down this path unless you're told otherwise. If the chest tube itself, meaning the part coming out of the patient, comes out, a little bit different ballgame. So now we need to apply an occlusive dressing stat. So this is like those Vaseline impregnated dressings. It's something that air can't pass through. So dry gauze, not okay, because air can still pass through that. It has to be something like airtight that we put over that area. Then assess your patient. So same thing, full respiratory assessment, all that kind of stuff. Make sure they can breathe, make sure they can speak, make sure they're oxygenating, all that kind of stuff, and notify the physician. The surgeon who did the procedure will need to decide if it needs to be the chest tube needs to be reinserted. Not up to us, but we are responsible for that patient assessment and exam to make sure it's safe for that patient to be in the condition that they're in. For discontinuing a chest tube in a planned way, what we're looking for is our pre-removal assessment. So this can be done at the bedside or in like a surgical suite. Either one is totally fine. If it's at the bedside, you guys are going to be on the hook for all this stuff. If it's in the OR nurse will be responsible for all this stuff. First and foremost, vital signs. Anytime you're going to do something weird to a patient, always just get a set of vitals first. It proves that they were alive when you started, which is always a good thing. Then full respiratory assessment, so like a focused respiratory exam. Then the drainage system. So assess the drain, note titling, note that it's hooked up to suction, the drainage that's coming out, serosanguinous drainage, serous drainage, how much, all that kind of stuff. Then, when the patient has stopped producing drainage into the chest tube, so there's no more fluid accumulation, that's when we expect the surgeon to come in and remove that drain. So these are all the things that we're assessing routinely, and when we start seeing that, oh, they've got no output in 24 hours, that's when that thing's going to come out. So patients should be without their chest tube for 24 hours before they discharge from a facility, from a hospital. It's because we want to prove after that chest tube has come out that they're able to not reaccumulate more fluid in their pleural space before they go home, right? So this is going to be a couple of chest x-rays. They're going to get one right after the chest tube comes out. They're going to get another in 24 hours to make sure they haven't reaccumulated any fluid into their pleural space. So then we know that whatever problem caused that has resolved and the patient should be safe to return home. The surgeon or physician will discontinue this. I've never seen nurses discontinue chest tubes. It's always been a physician. So yeah, I'm sure there's a set of circumstances where depending on where you work, like if it's a rural hospital, things like that, where you guys might be taking chest tubes out independently, but you're going to get a lot of training on how to do that before you're expected to do it. Don't think you're going to be expected to do this independently at graduation. Not going to be a thing. You'll get some specialized training if you're going to be the person removing these devices. After the thing is removed, patient's going to get an x-ray to try and visualize that fluid. That'll also be repeated because we want to demonstrate that the patient isn't reaccumulating fluid. And our respiratory exams are also really important. We need to make sure that physically the patient is tolerating the removal of that chest tube well. So for documentation, things we want to document, where it's inserted in the patient, left side, right side, and left chest, right chest, that's sufficient. We don't have to like count the intercostal spaces, that kind of business. And the dressing integrity, clean, dry, and intact, always a good goal. Drainage amount and description. So now we're talking about in the device. So what color is the drainage? How much is in there? The amount of suctioning that's applied, whether it's wet or dry. Presence or absence of tidal change. So we want to see that little ball going up and down with ventilation. Presence or absence of air leaks. So is there any bubbling in our water seal chamber? And then how is the patient doing? So the patient's respiratory status. Are they in any signs or symptoms of respiratory distress? Are they requiring supplemental oxygen? That kind of stuff. How they're tolerating the chest tube. So are they complaining of pain at the insertion site? Things like that. And then any patient education. One of the things I always educate patients on, basically I'm just telling them like, never hold that thing higher than where it goes into your body, right? Because it'll flow back into your body. And they're like, oh yeah, I'm not gonna do that. So that's patient education. Give yourself credit for it. Cool? All right, I'll put all these video links in the description for this video, but that's it for chest tubes.